All right, thank you guys so much again for being here. I really appreciate it. I know you all are so busy, but today I'm going to be presenting on substance use disorders, specifically screening tools, evidence-based treatment, and community resources for substance use disorders. And this is part of the Ethics Hub program through Rutgers Health. So thank you guys so much for being here. So what I like to start off with is addiction and common drugs of abuse. So I'm going to be really splitting this presentation up into 3 different sections. So this is going to be the start of the presentation. So we're really going to focus on addiction in itself and the different substances that maybe our populations will be familiar with, okay? So get a little education, little updates on what the kids are doing these days. All right, so before we start, I wanted to just ask you guys, what are some of the biases that you have in working with substance users? Part of being a good clinician, a competent clinician, is to be aware of your biases. So let me hear any of your biases, stereotypes, anything like that. Just shout them out. It doesn't matter what they are. Manipulators, excellent. What else? Criminals, right? Liars, family ruiners. Anything else that you guys think of? All right. Anybody? Bueller, anybody? Okay, so yeah, manipulators, liars, criminals, all these different types of stereotypes that we really have. Everybody has a bias in something, and unfortunately the substance use community has a huge number of biases in working with them. So what's really important in working with this population is having a sense of empathy and looking at these really bad things that sometimes drug users do as symptoms of their illness, just as sleeping all day and not taking a shower regularly is a symptom of depression. Lying and manipulating is a symptom of substance use. So trying to have that distance there so you can build that empathy. So addiction is a medical illness, and I think that's really important for everybody in here to know. It's a medical illness. It's a brain illness. It is not a moral defect. Most addicts, I would say probably all addicts, feel intense guilt and shame. Okay, so please keep that in mind in building empathy as well. It is not a matter of willpower. Why can't you just try harder? That's not a thing. If it was like that, I think that I would not be working in the substance use field, because I truly don't believe that people want to be living a lifestyle like that. And there is a genetic predisposition. Now that we have so much more advanced technology, we're able to actually identify different genes involved in the substance use biological components, but that's for another day. So one of my first addiction classes that I had in graduate school, the professor said, "Alyssa, try quitting something for 1 week." And I decided that I was going to quit coffee for 1 week. I have a cup a day and sometimes in the afternoon, but I quit it for 1 week. And in that 1 week, I got into 2 car accidents, 2 fender benders. I have never, knock on wood, been in a car accident my entire life, but I was in 2 car accidents because I was experiencing drowsiness. I was cloudy. I just didn't feel well. I was spaced out and out of it. And I actually got into, I was fine, everyone was fine, but I got into 2 accidents. So think about that, and also working with this population. Try quitting something for 1 week, maybe Facebook or social media, or something like coffee or anything like that. It really gives you a really interesting perspective, again, in building that empathy. So Dr. Michael Miller, who was the former president of ASAM, said, "At its core, addiction isn't just a social problem or a moral problem or even a criminal problem. It's a brain problem whose behaviors manifest in all these other areas. Many behaviors driven by addiction are real problems and sometimes criminal acts, but the disease is about brains, not drugs. It's about underlying neurology, not outward actions." So that's something that's really important that I think is, keep in mind when you're working with this population. And maybe not in the kids per se, but also their families, because chances are there's something like that in their families. When it comes to diagnosing a substance use disorder, DSM-5 had some changes. I know DSM-5 has been out for a while, but now substance use disorders are categorized as on a continuum, like other different types of diagnosing. So basically, they no longer kind of separate it into abuse versus dependence, those 2 separate criteria. They do have the same symptoms that they list here, for example, taken in larger amounts than intended, unsuccessful efforts to reduce or control use, etc. But they have it now in a continuum. So it would be substance use disorder, mild, if it has 2 to 3 criteria, moderate, 4 to 5 criteria, or severe, 6 or more criteria. So you would diagnose based on the drug of choice that they utilize. So it would be cannabis use disorder, mild, or opiate use disorder, severe. So that's part of diagnosing. There's also another specifier, which is in a controlled environment or on maintenance therapy. A lot of times, you know, when we would be working with kids, especially in inpatient or residential, they would be sober for like several months and therefore maybe not meet criteria for a substance use disorder, but they were in a controlled environment. So insurance was like, they don't meet criteria for a substance use disorder anymore. Why are they still here? Because they weren't able to access the substances. So I like that specifier a great deal. And they also talk about cannabis withdrawal, which is actually a thing. It's not made up. You can get addicted to cannabis, and we can talk about that in a second. According to Drug Free America, now don't look. What are some reasons why you think that teenagers and kids start using today? Try not to peek. Peer pressure. Peer pressure, yes, definitely. Anything else? Don't peek. You're honest clinicians. Anything else? Curiosity, yeah, definitely. Definitely. What else? Come on, guys. Family problems, absolutely. Peer pressure, curiosity, family problems. And according to Drug Free America, here are the top 8 reasons why teens try alcohol and drugs. The first is other people. Thank you, Lauren. Peers and family members. That's the #1 reason. Popular media. Think about, you know, any song out there, and chances are there's going to be a reference to drugs or alcohol. Self-medication and escape. Think about it. Drugs are the perfect solution to trauma symptoms. They work. That's why people do it. Unfortunately, long term, they have really not so good effects. But trauma, you're thinking about it, drugs allow you to escape, allow you not to feel, allow you to lower your inhibition so you don't have to worry about that hypervigilance symptom of PTSD. Drugs are the perfect fit. Boredom, rebellion, you know, doing something just to, you know, tell off your family members. Instant gratification. Remember the teenage brain. They operate on instant gratification. They don't have that prefrontal cortex development as much as us mature people, 25 and older. So prolonging gratification is a hard concept for them. Lacking in confidence and just general misinformation. Like, this is fine. Like, Molly is pure ecstasy, and there's no problems with it. It shouldn't be dangerous at all. Here are some common drugs abused by children and teens in this area, okay? I base this off of my own personal knowledge in working in this field, but also some research, you know, that I found online in different census reports. Synthetic marijuana. Has anyone ever heard of synthetic marijuana before? Okay, what are some names for synthetic marijuana that you may hear? Spice, K2, Space, Buddha Bud, anything? So when someone is talking about synthetic marijuana, spice, space, etc., what they're really talking about is just dried leaves from any type of plant with chemicals sprayed on them. Now, the chemicals have a really high concentration of THC, which can have a really negative impact on the brain. The chemical compound changes constantly, so it makes it really hard for people to test for it. So you'll see this a lot in the population of kids, maybe who are being drug tested for probation or a sports team or something like that. DXM, dextromethorphan. Has anyone ever heard of dextromethorphan before? Lauren has. So dextromethorphan is a chemical that's found in any type of cold medication. Mucinex, Coricidin, Robitussin, and you know, you hear some rappers talk about scissor or purple drank. Yeah, that's DXM. They will, I just said purple drank, yes. They will actually combine, you know, cough medicine with some Sprite. They may throw some Skittles in it, and that is something, if taken in a large enough quantity, it can make you kind of trip out, okay? Electronic cigarettes. Kids are having these really, really special little vape pens, and they bring them to school, and there's no smell, and there's barely any vapor, and they're putting marijuana in it, and tobacco. So it's really hard to even detect, and they're like this big, and that's them right there. And they could look like a little pen. So it's really hard to detect. Now, people say that electronic cigarettes are safer than regular cigarettes, but we don't have enough longitudinal research to really make that call. Prescription stimulant drugs like Adderall, Concerta, a lot of our kids here are prescribed with those medications, so we have to be really careful. Their parents, their siblings, you know, they're very high abuse potential. Synthetic psychedelics, which you can actually order online and combine with full directions on how to do it. MDMA or Molly, prescription pain medication, and as we all know about, this opioid epidemic in New Jersey and across the world, it often starts with abuse of pain medications. Benzodiazepines like Xanax and Klonopin, those are highly abused drugs. Alcohol combined with energy drinks, Red Bull and vodka. People like it because alcohol makes you feel great and it lowers your inhibitions, but it also makes you really tired. So the caffeine in the Red Bull allows you to keep partying. So when we're, hanging out at a party, at a rave or something like that, when we've had too much to drink, our body knows to kind of shut itself down. However, if we are drinking caffeine with it, we may be drinking more than our body can handle because we're staying awake long enough to continue consuming. So that's definitely dangerous as well. And opiates and opioids. Now here are some other lesser used drugs. Ephedrine, a diet supplement that some people use to kind of make sure that they're losing weight. GHB, which is one of those synthetic psychedelics. I think Kanye West in his new album talks about GHB. Soma is a muscle relaxant. Oftentimes people will layer that with heroin. It helps ease the withdrawal a lot. Kratom, you can go to New York City and go to a Kratom bar and you can have some Kratom tea. And Kratom is actually something that is a plant, and you can get it in tea form, pill form, and it relieves pain, enhances mood, increases focus, but it can be very dangerous, and especially since it's so easily accessible. And anti-diarrheal drugs. If you see someone with a giant box of Imodium, that's because they may be abusing it. Imodium has teeny trace amounts of opiates inside. So people will use a lot of Imodium, and they will use it to feel something. Like, you have to take a lot, but it happens. Okay, top drugs amongst 8th and 12th graders. It's marijuana, and they say hashish. I don't think any kid these days knows what hashish is, so I would kind of say synthetic marijuana as well. And inhalants and Adderall. Whoops. Okay, inhalants and Adderall. Be careful if you have an air freshener in your bathroom. If you have that computer cleaner, just be careful, okay? I saw it in our bathroom here recently, and the drug part of me is like, oh gosh, we have to get rid of it because it's dangerous, because someone can use it to, get high. 9 out of 10 people with substance use problems started by the age of 18, okay? That's huge. So if you meet an adult with a serious substance use problem, 9 out of 10 have started before the age of 18, which is why this job is really important. You're working with kids. You can catch it before it becomes as severe as some of the people that we've worked with, in substance use treatment centers. Okay, addiction and the teenage brain. Let me see if I can do this successfully. Here's a little video. A neuroscientist is discussing how the teenage brain is basically primed for addiction, and it's actually very interesting. It's really short, so.
More and more now people see addiction as a developmental disorder. We think about addiction as something that just happens to adults, but in truth is it really has its roots stem in adolescence. That's when most of the people who become addicted try drugs. For example, if you start using an illicit drug before you're 18, you have a 25% chance of becoming addicted. But if you start using an illicit drug after the age of 21, you only have a 4% chance of becoming addicted. So adolescence is a crucial time for the development of addiction. And I started to become very interested in that because I looked at the effect of nicotine on cocaine. And I found that actually nicotine has a very unique ability to basically loosen the DNA. And Eric was talking about gene expression. And when that DNA is loosened, what happens is that when cocaine comes along, then there's a much more massive increase of gene expression that's related to addiction. And in my research, I started looking at the effect of nicotine specifically on cocaine, and I found that nicotine has this effect that it increases gene expression that's related to addiction. But what I found actually later in adolescence was something very different. I didn't expect that. I thought that nicotine would do that even more so in adolescence. But I found something very different. Because when I looked at the adolescent brain at baseline, I saw that the DNA was already loosened up in that particular area in the brain, in the nucleus accumbens. So at baseline, the adolescent brain is much more sensitive to the effect of almost any other drug of abuse. And so if you expose the adolescent brain to any of those drugs, you'll get more of that growth that Eric described because the DNA is more open, basically open to soaking up new experiences. So this is a compact DNA, but you see that oftentimes in adults. And what I saw in adolescents was a very different picture. It was something more like that, a much looser DNA. So the gene expression, so the genes that are over there basically can get expressed a lot more in that particular stance when it's more loose.
Whoa, right? Did anyone know that? Had anyone heard anything like that before? So what is this guy kind of saying? What is this guy saying? Yeah.
And the conclusion that I'm drawing is that if you start it at this age, it kind of supports what you said before, the large percentage that leads to addiction.
Mm-hmm.
It's just right for it.
Yeah, exactly. I think what he said was the statistic was if you start using something before the age of 18 or 21, you're 25% likely to form an addiction to it. Whereas if you start later on in life, it's only a 4% chance. That's huge. That's giant. So that's just to share how important this is. Thank you. Okay, so this is another clip. I had the pleasure of speaking or hearing this woman speak a couple of weeks ago at a Rutgers training. She talks about cultural humility in our community, and I just always have to talk about this culture. She says cultural humility. People say cultural competency because you can't be competent in a culture. You can be humble and curious and understand. African Americans and white people use drugs at similar rates. Okay, so you can't say that black people use drugs more than white people. You can't say that. However, the imprisonment rate of African Americans for drug charges is almost 6 times that of whites. Same usage rates, but the punishment and consequence is 6 times more likely. And the Black and Latinx populations have difficulties in accessing treatment and are less likely to complete drug treatment than the white population. So just having accessibility to treatment and then completing treatment, if you even get into treatment, there's a huge disparity. It's very clear. And here's another little clip on this really cool person.
Justice. Decades of research has shown that African Americans are punished more harshly than whites. The most recent data from the Justice Department shows this racial disparity is growing when it comes to teenagers. Black children are 5 times more likely than white kids to be locked up. Brooke Feldman is a young woman with a unique perspective of what she calls the white privilege of the justice system. This is her story in her own words.
My life has been made up of many second chances. I can't even imagine where I would be without those second chances. My name is Brooke Feldman. I am a 37-year-old person in recovery. Growing up here, I had, I think on the outside what might have looked like a normal childhood, but I grew up without my biological mother. I didn't see her since the age of 4. My mom struggled with addiction, and I grew up being taught that addiction is a choice and that my mom was choosing to use drugs over being a mom. I ran away and I demanded, my dad tells me where my mom is. And he pulled over a few blocks from here at a playground and he said, I'm sorry to tell you this, but your mom died last year. And that was around age 13 that I found that out. And it wasn't long after that I ended up in my first institution, which would become like a cycle throughout my adolescent years. And I was at one residential treatment facility when I was between age 15 and 16, and I just was tired of being there. So I stole a staff member's car, and that wound me up in the juvenile justice system. And I watched black and brown girl after black and brown girl get sent to boot camp, which basically is punishment. And then here I was, charged with grand theft auto, and I was awaiting placement to get help. I was redeemable, whereas my peers of color, they were not treated as redeemable. I was able to go back to high school, graduate on time. And so I was sort of afforded the privilege of making a mistake and then not defining who I am in my entirety and not defining what the rest of my life would look like. And I think for many young people of color, that's simply not the case. So this is Fresh Start. This is the recovery house where I spent the first 9 months of my recovery living. And this is where somebody called in a favor and got me into a bed. Since I walked in there, it was July 19th, 2005. I have not used since then. Had I looked differently, had I talked differently, would that person still have called in a favor and seen something in me? And I don't know, but I don't think so. So on Monday, May 14th, I graduated with my master's degree from the University of Pennsylvania. My family got to watch me deliver a commencement speech at this Ivy League university. Whereas, before, I remember they attended my recovery house graduation, which was a big deal in itself at the time, but certainly not something that I or they ever would have imagined. My truth, which is that I am not where I am today solely as a result of hard work and determination and picking myself up by the bootstraps. I would not be where I am today had I not had a different outcome in the juvenile justice system.
Okay, what do you guys think? Any thoughts? That comes later. Sorry, sneak peek.
So Alyssa, what I'm thinking is, and I
Yeah.
don't know if I'm kind of taking this too far, kind of going into the logistics,
Uh-huh.
or what I think would be some of the logistics as to how this decision was made for
Yeah.
her with Grand Theft Auto charges to get into this, to have this wonderful opportunity.
Mm-hmm.
And so then I'm thinking, like, okay, whatever I do know about the juvenile justice system, right? And it has to do with the psychologicals and the psychiatric, all these assessments and evaluations. So then I'm thinking, if, say, 10 people were lined up,
Mm-hmm.
right? And we know there's a large disparity. If there were 10 people, there might be one or two, white juveniles, and the rest would be, non-white. And I'm thinking they all probably had their own assessments, right, by these
Mhm.
individual practitioners or hired by the courts, and they all must have stepped into that with this different lens.
Mm-hmm.
And somehow that this youth, it's a fabulous opportunity, but then there's 8 or 9 others who aren't getting this opportunity.
Yeah.
So I think it just kind of goes back to this cultural humility of each practitioner
Mm-hmm.
to kind of say, like, and what was it in that assessment that they found that these other youth may not have had?
Yeah.
So I'm just thinking it kind of comes down to a little bit of that.
Yeah. Absolutely. No, I would totally agree with you. We have to, as individuals, know our biases, be aware of them, and kind of keep them in mind. But I think this is like a much larger systemic issue, but it's something that we need to be aware of as we're working with this population. But yeah, totally agree. Thank you for sharing that. I appreciate it. The second section is going to be screening and diagnosing substance use disorders. So that's where we're going to move from there. Okay? Okay, so in any situation, a medical diagnosis or a substance use diagnosis will trump a psychiatric diagnosis, okay? So if you see a kid presenting with symptoms of depression, you need to first see, is this a medical issue, as we typically do, but also, is this a substance use issue? And we'll kind of see in a second that a lot of substance use issues can present as mental health issues. So we really have to always consider it as an option. I work with kids who started using heroin at the age of 8. So we really can't assume that just because a kid is 7 or 8 years old doesn't mean that they haven't had some experience with substance use of their own. In addition, 40% of adults in this particular survey also had a co-occurring mental health disorder. So not just a substance use disorder, but also a mental health disorder. And the data really shows that for adolescents, that number is much higher. I saw anything from 65 to 78% of adolescents had a co-occurring illness, not just one or the other. So we have to kind of have that broad viewpoint. We can't be pinpointing too soon. Some symptoms of drug-induced psychosis, and this goes back to the point where you can't diagnose a mental health if you don't look into substance use disorder. Pre-psychosis symptoms, a kid or someone having, maybe entering a psychotic episode, you may see a drop in performance, social withdrawal, bad hygiene, difficulty speaking. What do those things potentially sound like? Getting high, right? All of those things are signs that we tell our parents this may be a substance use issue. And active symptoms of drug-induced psychosis look like depressed mood, anxiety, suicidal thoughts, and hallucinations. That sounds a lot like other mental health disorders that we have, that we work with. So that's something to keep in mind. Thinking about it further, thinking about depression. What are some symptoms of depression? You guys know this. Bad hygiene, withdrawal, social withdrawal, sleep issues. Yeah, exactly. So you have someone maybe really tired and sad in your office, kind of stinky. They could be using heroin. You don't know that. I mean, because heroin, if you've ever seen a person high on heroin, you would see them kind of nodding off. They don't look too great. They're really skinny. They don't look like they're taking care of themselves. Could be depression. It could also be opiate use. ADHD also looks like amphetamines. If you take an amphetamine, you're bouncing off the walls. You're going all over the place, just like some of our lovely kids in our partial program. They're bouncing off the walls, right? Anxiety can look like stimulants. Bipolar disorder can look like methamphetamine use. People who are meth users will binge for periods of time, for several days at a time, where they do not sleep. They have more energy than anything else in the world, and then they will crash. What does that look like? What mental health issue does that look like? Periods of really hyper times, not sleeping. Bipolar disorder, yes, exactly. And schizophrenia, psychotic disorders, personality disorders can look like any serious substance use disorder. Think of a person in active addiction. They're like really struggling. They're lying, they're manipulative, they're having chaotic relationships. That could look like someone with perhaps borderline personality disorder. So these are all things we need to really think about. When to screen? Literally always screen. Always. And we'll see in a second that when you're screening for a substance use disorder, you're doing so formally with, of course, evidence-based screening tools and all of that, but you're also doing it informally with your instincts, okay? There is a voice that doesn't listen, that doesn't use words, so listen to it. Rumi, he's my dude, okay. Denial, remember, denial is one of the primary symptoms of addiction, okay? So if you sit down with a teenager and you say, have you used substances before? Chances are they will say what? No, of course not. If they're actively using substances, they're going to say no, I'm not using. Or I know you're here because you were arrested for marijuana possession or something like that. Tell me about the problems you've had as a result of your marijuana use. I've only smoked it once. It was just this one time, and that was it. I got caught. It was bad timing. It was my friend. He put it here, whatever. So remember that kids may not always be telling the truth. So that's why we love urine drug screens. That's a really great thing to do. I don't know how often they are used here, but it's also a really good test because you can't really lie. Focus on what you see, not always what they say. So you're going to note any behavioral changes or odd items or possessions. So notable behavioral changes, very similar to concerns that parents may bring up about their kids potentially having a mental health disorder. Anger outbursts, lacking of motivation, missing school, lower grades, any previously diagnosed mental illness. So those are your informal screening tools that you're kind of looking at. You're asking parents, you're asking people in their lives, you're asking if they've seen any of this outside of the area that you're doing the assessment. Also, presence of paraphernalia. Items that you may feel are completely innocuous may be used to use drugs. For example, mouthwash. Anyone know why mouthwash is used sometimes by kids? Alcohol. There is a very, very high concentration of alcohol in mouthwash. And kids can kind of just go to the store and buy mouthwash. And that's that. But a lot of kids may drink the mouthwash to get drunk. Anybody can think about maybe a pen tube, why that may be, how that could be finagled? Storage, exactly. A lot of kids will put it in their pen cap and then they'll close the pen and it's just a little pill and you don't even know that something else is in there. Also, it can be helpful in snorting, kind of contain all of that and create a little tube. Dryer sheets. I know Debbie has them all over her office, but we're not worried about that now. Dryer sheets, a lot of times in a residential, I saw a kid take a paper towel roll and put dryer sheets all over the paper towel roll. And when she would decide to have a cigarette, she would light the cigarette and she would breathe out into the tube so the dryer sheet smell, masked the smell of the tobacco. Yes, very creative. Very, very creative. So very interesting, huh?
Did it work?
Yes. Yeah. It was we caught her eventually. But she was doing it a lot more than we thought.
And putting towels underneath the door.
Oh yes, towels under the door.
So towels you would think would be
Exactly. Just general observations. This is a nice list. Please look at their face. Look at their eyes. Are their pupils gigantic? Is their nose maybe a little funky looking on the tips of their nose? Are they shaky? Do they smell? Perhaps you can smell some sort of alcohol or marijuana. It's very pungent. So really just have your wits about you when you're screening. So also, I just wanted to kind of let you guys know, this is an example from when I was working in adolescent inpatient unit. There was this Caucasian man, he was 17, he was a gentleman, presented to the adolescent inpatient unit for a suicide attempt, which is what was reported. He ran into traffic on a busy road. So they brought him in, and he was very physically active, he had tons of friends, he was actually the captain of the football team. He was upper middle class family in a nice neighborhood in New Jersey. And because he was the captain of the football team, he must have passed some sort of physical exams, drug tests, but he was exhibiting signs of psychosis. He was totally delusional. He thought he was, and this is not a joke, but he thought he was in a rap video, like constantly in a rap video. It was actually really upsetting. Visual hallucinations. We could not figure out what was going on with this kid. It just didn't make sense. He was very high functioning. It didn't make sense. So with time, we realized that he was smoking spice, which was allowing him the chance to get high, but also pass his drug test so he can continue to play football. Luckily, this young man was able to clear, but some kids, unfortunately, can have such detrimental effects from spice use. Their psychosis can last years. So it's very dangerous. Treating minors for substance use disorders, please be aware of consent. If a client applying for participating in a substance use program is a minor, the minor's consent is required for disclosure of protected information, even to the minor's parent or guardian. So typically, if they're the age of 14 or older, they can say, I don't want my mom or dad knowing this. They have to have an additional consent saying that they're okay with it. However, I always like to say, if you're severely concerned about that safety of that child, you can protect that child in that way by sharing with parents. But other than that, if they're like smoking marijuana here and there and they don't want their parents to know, you might not be able to tell them. So consult with your supervisor. Screening tools. These are there's like 1 billion different screening tools for substance use disorders. The HUB program uses the CRAFT for substance use screening, but I'll just go through briefly. Most of them are like question answer. Have you ever done this? Have you tried this? Has this ever happened? So this is what the CRAFT looks like. The way you start it is you ask these 3 questions to start. Have you ever had alcohol, more than a few sips in the past month? Smoke marijuana or hashish, or I like to say synthetic marijuana, or use anything else to get high? They say no to everything, and you've done your informal assessments as well, and you think that it's probably not an issue. You stop after you answer the question, have you ever been in a car with someone under the influence? And then you stop. The assessment's over, okay? But if they answer yes to any of those questions, you must continue the assessment to kind of get an idea of any problem areas. What kind of areas has been negatively affected by their use? Have you ever used to relax? Do you use when you're alone? Do you forget things you did when you're under the influence? So I like that one. That's probably one of my favorites. Now also, when you're screening for substance use, remember what a real drink of alcohol is. So some kids may say, I only had 1 drink, but really they poured like half a cup of vodka in and mixed some Sprite into it. That may be 5 drinks because they may have had 5 shots. So 1 drink, 1 unit of alcohol is a half a pint of ordinary strength beer, okay? So not these craft beers that are like really popular these days that are 10% alcohol, a small glass of wine, a single measure of spirits. I don't know any teenagers using spirits or sherry or aperitifs, but you never know. So just keep that in mind as well, what a real alcoholic drink is. Here's the cage. Really just, take a look at it, really just looking at different areas that may be problematic, that there's something to look at if this person may have a substance use problem. So that is the cage. An eye opener. That's my favorite. I never knew they were called eye openers. I always heard hair of the dog that bit you. When you have a drink in the morning to just make yourself feel better. Nobody knows about that, obviously. So here's the DAST 10. So it's a 10-question item. Have you used drugs other than those required for medical reasons? Again, more yes or no questions, which is hard because these kids are, they're in denial, they might not even realize or they don't want to tell you. So that's why, informal screening tools or screening is really, really important. And these are all accessible online. The last section, and I appreciate your patience and working through all this with me, is treatment and referral. So like, what should we do as therapists and where can we send them if it's out of our scope of practice? Before beginning treatment with a substance user, remember that a lot of times when a substance user is seeking treatment, they're at like a really low place. They may have gotten kicked out of their house. They may be homeless. They may have been fired from their job. Their parents may have completely rejected them. And I think at this point, we're probably not getting kids like that here, but maybe a parent, may have had an experience like this. Treatment will be more successful, if they have access to safe housing and education. So we're looking at Maslow's hierarchy here. We need to focus on the basic needs that the people have before we start utilizing, a cognitive behavioral technique. Because if they don't have a place to sleep, they're not really worrying about their, cognitive distortions, of course. Also to remember that an addiction is a family illness, so the addict may be the presenting patient or the identified patient, but chances are it's the entire family that's involved. So these are some kind of roles that I see a lot with substance users and within families, and I'm sure any dysfunctional or regular family, no one's perfect. They have these types of roles and they like to stay at equilibrium. Maybe it's not healthy to be at that place. But, they may blame it all on the addict, the scapegoat, but really the whole family is going to need to change. So any treatment really needs to incorporate the entire family. Gotta educate your parents. Lock your medication cabinets. There's no reason not to, right? My kid would never do that. Well, you don't know, or maybe a peer who's over the house could take something. You learn to dispose unused medications. Do you really need that bottle of Percocet from your wisdom tooth surgery from 10 years ago? No, I don't think so. I don't think there would be a reason for that. There are pill drops at any local police station where you can just bring them, and that's that. They dispose of them for you. And have your guardians talk to the children, have the guardians talk to the kids, no matter what, okay? Okay, so this is one of my favorite examples of family denial and enabling, okay? This is a true story. At a youth at co-occurring residential treatment center, the reason why he was admitted was because he overdosed and nearly died after taking a lot of DXM. Does anyone remember what DXM stands for? Dextromethorphan. Very good, very good. So he nearly died, okay? And he came from a middle-class family, really, they had means, they were obviously concerned. And this young man developed a cold while he was at the program. So he called his mom and said, Mom, they don't have cold medicine here. They just don't have it. I don't feel well. Can you please bring it to me? I really like Coracetin cold and cough. That's what helps me the most. So this young man, unbeknownst to myself, was given Coracetin cold and cough by his mom, and he brought it back onto his unit because he kind of was able to hide it, and he overdosed and was hospitalized. And when I talked to him about where he got this medication, he said, my mom brought it for me. She was just trying to take care of me. I called the mom, a little concerned, and she knew that her son had initially overdosed on triple C's, but she thought that that was vitamin C and that he was just asking for vitamins, okay? So I don't know, did she really not know? With the amount of education that I had provided for her, I would be, surprised if she didn't really understand, but regardless, that's like the family not wanting to change kind of aspect too. Families prolong this, maybe not intentionally or in a bad way, but they really do prolong this addiction cycle. Okay, last little clip. We're almost done. Oh dear. And this is just a little clip from, I guess, a recovery house on, family enabling.
Talk about how denial gets in the way of recovery. Specifically, how a family's denial that there's actually a problem going on or a problem serious enough to address can prevent someone from ever having a chance to truly recover. Here's the thing about denial, and here's the thing about addiction. There's a lot of shame and guilt associated with it. And so it's really uncomfortable as a parent or a family member to acknowledge that, hey, maybe my kid is actually struggling with addiction. This isn't just normal experimentation or them making some mistakes. And And so what will happen is parents will justify behavior. You know, that money that's going missing, no, there's no way that little Johnny could do that. There's no way that he would steal from me. That big behavioral change, the sullenness, the irritability, no, that's not addiction. That's just normal teenage hormones. The bad grades in college, well, you know, I'm going to keep sending the money because at least he's staying on campus. He's just going through something hard right now. This whole time, there's a serious problem taking place, but because we don't want to look at it as family members, because it's uncomfortable for us to acknowledge that maybe what my kid is struggling with is more than just some bad decisions, but is actually addiction and something a lot more serious, them getting the help that they need doesn't happen when it needs to happen. See, in order for you to look at the problem and in order for something to happen and it to change, you've got to first acknowledge that it exists. As long as you're not willing to acknowledge that a problem exists, as long as you want to keep painting it something else and hide behind prevention, hide behind, you know, teenage behavior, hide behind everything outside of addiction, there's no hope for a change to take place. You know, how is recovery going to happen and how is someone going to finally get healthy if you're not willing to point something out and say, hey, this is an issue, this isn't okay? That would be like a doctor going into the office, and when a patient comes in with all the symptoms for the flu saying, you know what, that runny nose, it's probably not as serious, it's probably not something you need to take medication for. The problem never gets fixed, right? It's the exact same way with addiction. The only difference is that a lot of the time when it comes to denial, it's really uncomfortable for us to look inside of our own homes and look at ourselves and walk through that uncomfortability that prevents us from acknowledging a problem and doing something about it.
I think more and more now people see addiction as a developmental disorder.
Sorry, I'm not very techy. Okay. So I really like that. You know, it just shows you really just, in general, you just need to be looking at the whole family as well. Okay. So in terms of treatment, I know you guys, you're providers, you also make referrals. There's a lot of things that you already know, but I just have it just briefly for you. Perform Care, it's a great resource, of course. They have separate listings for substance use treatment centers and providers. Care management organizations, typically a really good thing because the care manager is able to get into the home and kind of see what's going on. That's also a really good technique. Support for families. A lot of people have difficulties confronting families with denial or enabling. So having an FSO is really great. A peer will come in and help the family, someone who knows what it's like to have a child with an addiction. And that really allows them to see it from someone who's going through it themselves. It may be a little bit easier. And it's so support for the parent. 12-step meetings, NA, AA, Al-Anon and Alateen, Nar-Anon, those are Al-Anon and Alateen. Those are meetings for people who have users in their immediate family. So like the mother of an addict may come to an Al-Anon meeting, and they're really great. They're awesome. Outpatient services in our area, we've got Gen Psych, High Focus, YCS, The Bridge, Newark Renaissance, Summit Oaks, and Family Connections. They all have substance use treatment, depending on that level of care that's needed. There's also recovery high schools. I don't know if anyone knows that, but there are a few high schools that are based on sobriety concepts. So the Robert Lesniak School and Daytop Academy in Mendham, they have the whole high school, the whole schooling experience is based on recovery. Because you think about it, if peers are the biggest reason why kids use, it's really hard to be sober as a young kid in high school. So this offers a really good opportunity. Rutgers, TCNJ, and Montclair State also have sober living dorms, which I think is fantastic because when you're starting off in college, binge drinking is the thing to do. So if you're in recovery, your recovery is at risk. You don't have that stable, safe house. New Hope has the only adolescent substance use detox center in New Jersey. All of the rest closed down. So there's only one left. So
Has that been open for a while?
yes. So it's definitely, and you know, before you initiate treatment, you have to make sure that the detox isn't necessary because it can be very dangerous if it's done in an unassisted way. Residential, there's co-occurring and substance use only treatment centers throughout New Jersey. You can look at care managers for that list. I came from here. Oh, yes, that's where I came from. And it's a co-occurring level of care. So that's the first time New Jersey ever had this level of care. Behavioral health and substance use. That's what BHSU stands for. It's pretty amazing because I don't really believe that there's a delineation. I think that it's both. So that allows the person to get the most comprehensive type of treatment. Evidence-based treatments that work. motivational interviewing, you guys know this, motivational enhancement therapy, CBT, modifying your dysfunctional emotions and thoughts surrounding your use, and contingency management, using operant conditioning. There are some things that you could take that, if you ingest alcohol, you'll get sick. So kind of utilizes operant conditioning to kind of train the person and help the person. That it really doesn't use so much. I haven't really seen it, but I think it's interesting. This is really hot right now, the craft model. And basically what that is utilizing the entire community and getting the entire community of that person involved in the treatment. So the family's aware, they know what to do, they know how to talk to the person, how to support the person, and changing the way the family reacts to that client, that family change that's so very necessary. Relapse prevention, if you're sober for 2 months, that does not mean you're done, okay? It's a lifelong thing, okay? So long-term care and follow-up is required to prevent relapse, but also know that relapse is a part of recovery. Here you kind of have the stages of change, but for a substance user, oftentimes relapse is a part of it, okay? So it doesn't mean that they're done, that they failed, that that's the worst thing ever, and that they shouldn't try again, but it is a part of it. And the last thing is pharmacotherapies. This is particularly important with the opiate using population. We know that to treat opiate addiction, it's really most effective to use, like talk therapy, all those different models that we just talked about, in addition to medications, okay? So that includes Suboxone, naltrexone, and naloxone. Who's ever heard of naloxone before? Yes. What is it also known as? Narcan, yes. Narcan is that opiate antagonist that prevents overdose. So Demi Lovato just overdosed recently, unfortunately, and I think her friend had Narcan on hand, and that's how she helped her survive. Naltrexone is also known as Vivitrol. It's a one-time-a-month injection that's started after the detox is complete, and that helps, helps a person to not feel the effects if they do decide to ingest opiates, to not feel that euphoric feeling, but it also helps to make sure that you don't overdose. Suboxone is also important too because it has naloxone in it, buprenorphine with naloxone, which can also protect a person for overdose as well. So I believe that is it.